Thanks, Chris, for asking me to come and speak today. And I thought the topic that we'd cover is the use of ECMO for cardiac arrest. There are many people that have helped contribute to the data and the information in the slide, and I've listed them all there. And it's one of the more exciting interventions we have, is being able to use a powerful therapy like ECMO in a setting where the mortality, as you know, is very, very high and turning around some cases. When most people think about the subject, they think about a paradigm that's quite simple. They think about a cardiac arrest, you've got an intervention called ECMO, and you've got a desired outcome called survival, and we should be able to talk about this in common terms quite simply, but it's not the case at all. A much more realistic view of it is this flow diagram, which says that, essentially you can divide prolonged cardiac arrests into where they occur, out of hospital and in hospital, but for each of those there are a whole lot of different patient groups that have cardiac arrests in them, and they'll all have quite different outcomes, and not all cardiac arrests are the same. The majority of cardiac arrests that are prolonged include some ROSC, and defining ROSC is even not standard. Some people define ROSC as a minute of circulation, some say greater than 20 minutes of circulation. So getting parity in terms of what the condition is you're treating, what was the underlying disorder, how long it occurred for, and how refractory it was, is all quite uncertain. The only thing that binds them all is the treatment. We apply the same treatment pretty much to all of them. And then in terms of outcome, there are different survival outcomes. There are some people that survive as a result of ECMO, followed by the use of a VAD, followed by a heart transplant, which is hugely expensive. There are some people that survive brilliantly with a short run, and there are some people that survive with long-term neurological impairment. And so costs and quality of life is a really big factor, depends on the program, and the neurological outcome is a very variable outcome. As well, there's another quite favourable outcome, which is organ donation. So it greatly facilitates the pool of organ donors that exists if you apply ECMO to protracted cardiac arrest populations. And there's another outcome, we'll talk a little bit about the people who are unsupportable on VA ECMO. What I thought I'd start is just to talk about some of the definitions for cardiac arrest for ECMO. What we use in our database, ECMO commenced within 30 minutes of a cardiac arrest for which you've had more than 10 minutes of conventional CPR, or the patient's been unconscious as a result of their cardiac arrest. When I created the database, the definition I chose was based on the definition for the application of therapeutic hypothermia once upon a time for cardiac arrest. Bearing in mind, they're the group, the most likely outcome that we were fighting against was an acquired brain injury from hypoxemia, and so that definition seemed the most relevant one for us to choose at that point. The first people to really promote the use of ECMO for prolonged cardiac arrest were the Taiwanese. They did an in-hospital population. One of the reasons they could do it is they had a rapid ECMO initiation program, and they have a massive 2,000-bed hospital with quite a small ICU. Now, whenever you have that imbalance, what you have is a lot of cardiac arrests on the ward, because you've got a lot of sick people that can't get into ICU to prevent the cardiac arrests, and their cardiac arrest rates are fantastic by our standards. They gave them a lot of practice of this technology, and so a lot of large numbers. The group is not well described, but they had cardiac arrest necessitating chest compressions or open cardiac massage. They'd had more than a number of cycles with adrenaline, could not be returned to spontaneous circulation within 10 to 20 minutes, and subsequently received ECMO in hospital. So clearly would include patients with return of spontaneous circulation at some point and going on for subsequent heart failure, as well as people who have no return of spontaneous circulation. So that was at 2003. So if you jump right through to this study, which is probably the cleanest data we have in this area, this was a Japanese study, a prospective cohort study for cardiac arrest in different regions of Japan, some of which could provide ECPR and some of which could not provide ECPR. So the centres were allocated to either provide ECPR as per protocol or not, and then everything that went through was monitored prospectively. It's a really good design. What they did was looked at, you needed to have VFVT on your initial rhythm, cardiac arrest on hospital arrival without any ROSC pre, within 45 minutes from reception to emergency call, and no ROSC for the next 15 minutes after hospital arrival. then you were in the study, and ROSC was defined as 1 minute of continuing pulsations. That was the definition they used. So for an out-of-hospital population without return of spontaneous circulation, that's the group that you can follow. We'll talk about what results they got later on. But that was the definition they used in that study. And if you look at, so ELSO is the Extracorporeal Life Support Organisation, which sort of is the unifying world body for ECMO application, and they maintain the largest registry for ECMO patients in the world. And the registry defines ECPR as part of initial resuscitation from cardiac arrest. So it's a pretty broad definition. It would obviously include patients who got return of circulation before going on to ECMO, but were just unstable. It even includes, if you look at some of the people in the cohort, it includes people getting VV ECMO, which wouldn't even support the heart. So by definition, they have to have return of circulation to have that. A lot of mixed modes afterwards as well. So it's hard to know exactly what constitutes that population. And just to give some contrasting definitions, in one other study it was defined as VA ECMO to treat cardiac arrest, very unclear as to who'd be in and out of that group. And in the other one, within 20 minutes after return of spontaneous circulation, but he had to have 10 minutes of CPR. Again, another one was, this obviously included people who'd had spontaneous return, but had a different definition for ROSC. Our big problem with this area of investigation is that it turns out the majority of patients that may benefit from ECMO, who don't have enough circulatory power after a cardiac arrest, have had some return of circulation at some point during it. And it really matters to what extent if you want to do comparative studies. That's an essential point. It's also common for patients who are getting ECMO primarily for cardiac failure to have had some sort of short cardiac arrest before. Turns out about a third of people getting ECMO just for heart failure have had a brief cardiac arrest in the period leading up. So that's common. And definitions for what constitutes return of spontaneous circulation are lacking, and cardiac arrest occurs in many different settings from many different conditions. So these are some of the challenges we have in comparing outcomes and doing comparative studies in the area and moving forward with it. Does it matter much? Examples of this are not that strong at the moment. They come from case series looking at outcomes from VA ECMO, and generally the additional risk to your survival after you receive ECMO, if you've had a refractory cardiac arrest, seems to be somewhere between 4 and 20 times your mortality risk without a cardiac arrest. So if you get massaged onto ECMO, you're between 4 and 20 times more likely to die than other VA ECMO patients. If you have an arrest with ROSC, that number is more closely around 2. You can see it does matter quite a lot, and there are some examples. These are some of the case series and the reviews that have showed that. It would seem to me that going forward, what we need to do is define our population we want to study for the benefits of cardiac arrest resuscitation. And this is a study from the United States, a prospective cohort study from a large number of centres, and it had, I think it was one of these mega trials with 100,000 people enrolled in this for out-of-hospital cardiac arrest survival rates for all comers in the US. What's interesting to see that even if you just have a 1-minute CPR duration from your cardiac arrest, your chance of leaving hospital, and you go to hospital, your chance of leaving hospital are 6%. And it falls from a terrible number of 6% for all comers for cardiac arrest in the US. And you can see that down around the 20-minute mark, the chances of you having a good neurological outcome and recovery from a cardiac arrest become vanishingly small. Any chance you have of leaving hospital well pretty much means you need to have your CPR limited to less than 20 minutes before you come in. For in-hospital mortality, the same graphs don't exist, but this is a similar documentation, again a very large US study for in-hospital cardiac arrest, and this just shows the proportion of patients getting return of spontaneous circulation. And again, you can see at about the 20-minute mark, the number of patients, if you extend conventional CPR beyond 20 minutes, becomes vanishingly small for additional gain. This is another Korean study, and it's remarkable in that it has a very heavy database attached to this patient group. So this is a cardiac arrest database where everyone who's had a cardiac arrest brought into this hospital or occurring in this hospital have very extensive data collection, and it's been analysed. And some of the information from it was that if you look at the first set of bar graphs on the left as you look at it, they are recoveries from prolonged cardiac arrest, and they've been divided divided up into cohorts of less than 21 minutes, 21 to 40, 41 to 60, and so forth. And for conventional CPR on the left, pretty much all the survivors with good neurological outcomes, so they're the black bar graphs, occurred in less than 21 minutes. And that shouldn't be surprising to you, to know that people with out-of-hospital cardiac arrest who have more than 20 minutes don't do well. For people who got ECPR, got ECMO added, there were survivors right out to up to 80 minutes, though the numbers did drop off past 60 minutes, which seems to be very significant. And if you do a receiver-operator curve for standard CPR with good neurological outcome, receiving just conventional CPR, it turns out that 21 minutes tends to be most predictive for bad outcome. That pretty much everyone after that has a bad outcome, and everyone who's going to have a good outcome occurs before 21, and that's why the area under the curve's so high, 93%. So it would seem to me that there's enough there to say that 20 minutes conventional CPR would be a group that you'd be interested in improving their survival because it's miserable beyond 20 minutes. That would be the first thing, I think, that we're trying to get integrated into future classifications. The next sub-classifications we need are the pathological classifications, whether or not there's ROSC, whether or not it's out of hospital, and the initial rhythm and witnessed are pretty much all we need to collect, I think, from there on, and then we can classify according to that. And the reason we need to do it is because people getting exposed to this therapy vary greatly across the world. Who is excluded from this is not the same everywhere you go. So these are our ECPR exclusion criteria on the Alfred colouring over there from one of our ECMO CPR cards, which we would say that if you're over 60, you're out. If it's an unwitnessed arrest, you're out. If the first check rhythm is asystole, you're out. If it's greater than 10 minutes from witnessing the collapse to commencing CPR, you're out. And if you're not in hospital by 45 minutes, because we anticipate about 15 minutes to get onto support, it's going to be beyond 60 minutes, you're out. And also, if you have another chronic illness that's caused your cardiac arrest, you're definitely out. If you have a cardiac arrest at the end of your cirrhosis process, there is no point resuscitating that patient. If you have it at the end of your cardiomyopathy process, there's no point resuscitating that patient. So this is our ECPR for both in-hospital and out-of-hospital exclusions. They would all be true. Whereas an example from one of the Asian centres was up to 80 years of age and terminal state malignancy. And also, this is for out-of-hospital cardiac arrests, ventilator dependent for greater than 3 months would be an exclusion criteria. Well, you wouldn't think there'd be too many of your cohort having that problem. But you can see that the threshold's much higher in many other systems, so the people getting exposed to the therapy are quite different. Populations are different. I'll change now from how we need to study the problem and what definitions we need to a little bit about the approaches and how we do it. Obviously, the most important approach to ECPR success is time to ECMO. So shortening CPR compression seems to be the main benefit, and restoring circulation seems to be the main benefit of ECMO. So the sooner you can do it, the better your outcomes. That's pretty clearly demonstrated. And there are two techniques around the world. One, so the top is our old photo of our ECPR trolley with the auto pulse chest compression device on it, which has now been replaced by the Lucas 2. And that is a similar photo from a Taiwanese hospital that does open cannulation. You can see they've got a lot more surgical equipment and suturing equipment that you need. We don't need that because everything's done percutaneously with ours. They're pretty similar in time, but it has big implications for how you staff your service. To do the bottom one, you need people trained in open cannulation present 24/7. And a lot of hospitals have surgical fellows in overnight and no intensivists, but we have intensivists in overnight and no surgeons in overnight at our hospital. So is the model we've moved to. So it'll largely reflect which of those two. Most people don't think this is possible, but we've been doing it ever since we started, which is largely doing all the cannulation by percutaneous cannulation with ultrasound guidance. It does involve less than 60 seconds of circulatory arrest because you've got to stop the chest compressions while you put the needle and the wire in, which is one of the costs of it. Whereas if you do open approaches, you can maintain the chest compressions when you do it. The other aspect to that, of course, is being able to access the subcostal view of the IVC, and that's That's extremely important because one of the things that's quite easy to do during ECPR, as you can imagine, is put either both wires in the arteries, and that would give you AA ECMO, which won't help, to put what you think is a venous wire and an arterial wire in the wrong vessels, and you could potentially run ECMO the wrong way, from arteriovenous or VA, or you could run VV, which won't help much. So it's very important you know which vessel you've entered, and they're not pulsatile, and they both have dark blood at the time of arrest. So the best way to know that is with the transthoracic echo probe placed subcostally. You get the IVC view, and the aorta can look quite similar during a cardiac arrest, but there should be some sort of pulse wave Doppler signal in your aorta that's different to your venous if you need to categorise the two. But normally you can tell through the intrahepatic segment where you're venous and where you're arterial. And you want to see, obviously, a wire in your vein, and then you know that's your venous, and then you don't want to see two wires in your vein. The other problem with peripheral ECMO is this problem, which is downstream compression of the femoral artery. So if you stick the cannula in the artery, one of the problems is it squirts down the back wall of the artery and or fills the whole lumen, so there's very little flow past. And whether you put it in surgically, as in the bottom case, or percutaneously, this is a problem. You need to provide some other way to get blood flow down the leg. What we traditionally do, so looking at the ultrasound picture there, it's the common femoral artery with the head out to the left as you're looking at it, and to the feet at the right as you're looking at it. We want to put the ECMO cannula obviously up the common femoral artery up to the patient, and then a second cannula down the superficial femoral artery. So that's our ECMO to the patient, and that's our distal perfusion cannula down the leg. And that way you can take some of the ECMO circuit flow and send it to the leg as well as to the patient, which prevents the leg ischemia. Now that turns out to be the hardest part of the whole procedure and the most time consuming. And happy to say that we've just started using these. So these trials started in the operating theatre yesterday, so it's timely that we've now got a bent cannula with a distal perfusion hole in it. And so this will allow us to just use the one return cannula rather than the two. And the design feature is that there's a widened shoulder just where it goes into the vessel. You can get tactile feedback when that gets inserted, and then you pull it back and it straightens out the downstream compression issue, and it sites the hole right in the middle of the vessel. Okay, so the next problem I want to talk a little bit about is, so that's how you cannulate for VA ECMO. Some of the patients become unsupportable, which is, you think might not be possible. So if you think about it, if you take blood from the venous side, return it to the arteries, it's got nowhere else to go, you would think, other than to flow back from the arteries round to the veins and go round again. So when that doesn't happen, you have arterial failure, right? The blood you put in the arteries is not going back to the veins, is the only way I can put it. And so arterial failure doesn't have that many causes to it. Bleeding is the commonest, right? Okay, so if you've got bleeding, and so would bleeding be common after prolonged chest compressions? Yeah, you combine it with the other interventions these patients tend to get, platelet inhibition or thrombolysis, and you get a lot of bleeding. And prolonged chest compression devices can create a lot of blunt trauma that will bleed. So that's by far the commonest. The second commonest, so if it's not squirting out of an artery, big clot, yeah, that's possible but very uncommon. Don't think we've ever seen that. The other one is that instead of going from the arteries to the veins, it goes back across the aortic valve in the other direction. And that is fatal. So if your heart's not pumping anything forward and you're putting 3 litres a minute into the aorta, whatever's going back will never come out of the heart. So it will, bit by bit, fill up the left ventricle, then the left atrium, then the pulmonary veins, so then the alveoli, and then the airways, then the endotracheal tube, and then the ventilator tubing, right? That's what it will do. So it's actually fatal. So there are some people, paradoxically, that can't be supported with VA ECMO, and they are people who are bleeding and people who have aortic insufficiency. The circuit won't run. So the kind of times this happens is if you have a totally non-pulsatile circulation and you have any significant AR followed by mitral regurg. The first sign of this is that the circuit won't run. You can't get blood back into the circuit because not all of it's coming back round. So that's a bad sign. And that's not an uncommon problem in these protracted chest compression, bleedy patients with non-pulsatile hearts, is that the moment you put some load on the aortic valve, it leaks a bit and then you progress from there. You can't do much about that. So peripheral VA ECMO can't support those problems is probably the most important thing, and it will eventually fill back right up to the ventilator. So you should probably stop therapy before the ventilator is destroyed with the blood. It's not good to put blood through ventilators. One of the ways to get around that problem, what we need is a approach to empty out the left side of the heart when that happens. And the options are, a lot of these people go to cath lab, and so one option is to leave the pigtail angiocatheter that goes across the aortic valve, an LV gram, leave that cannula in and connect that to your draining side of the ECMO circuit and take some blood out that way. That's probably the simplest, but the factors against that are that you would have it's easy to do, but you've got a long tube with high resistance, you won't get much flow through it, and it might be inadequate. The second way to do it is to put a left atrial percutaneous cannula in. So these exist from a device called a tandem heart. It's pretty much an ECMO cannula that's designed to go across the interatrial septum into the left atrium and stay in place there. And what you can do is connect two drainage ports, one from the LA and one from the RA, connect them with a wire connector, and then return to the femoral artery down below, and that will get rid of that problem and support it. We don't have access to that cannula, so we're trying to do it now with a new cannula percutaneously into the pulmonary artery. Try and empty the left side via the pulmonary artery. We're not sure how that's going to go actually, but we're going to give it a go. Probably about a third of our patients fall into that sort of category, become unsupportable after ECMO, and so don't get to brain testing. The other thing that's changed recently is we used to do a lot of 33-degree temperature management in this group. We've now probably changed to 36. The protocol still says 33, but I've spoken to Steve Bernard, who's finally agreed to change it back to 36, which means he out of his own money, he bought a bar fridge which sits in the ECMO equipment to keep cold saline in it, so that we always had cold saline to cool our patients quickly. But he's going to take his bar fridge home with him, and we're going to start aiming to 36. The problem with 36, if for cardiac arrest, is that it's a really good lesson, this one. It's a really good lesson of the difference between research and clinical and translating into clinical practice, is that if you forget ECMO patients, just have cardiac arrest patients admitted to ICU, if you make the target 36, the first thing people do is don't use cooling devices. They say 36 is normal. The patient will just be 36. And of course, the patients were never 36. They were 37 often, or 38 often, because we didn't have cooling devices on them because we were targeting 36. That was the mistake we made. I think we've woken up to that, and we're now starting to be more aggressive at keeping people at 36 or under. Whereas when you had to get to 33, you were forced to use a cooling device, so you always got there. With ECMO, it has an integrated heat exchange device, so we can cool them down to any temperature we want. The other thing is what oxygen target to have after cardiac arrest. So there is retrospective data that looked at outcomes of post-resuscitation oxygen tensions in patients, and found that, when you looked at it retrospectively, that people with, in a large group, people with normoxia did much better than people with hyperoxia. Now, there might be lots of unaccounted for confounders in that sort of study, but it is interesting that the people that had higher oxygen tensions did worse. And it's being studied with a lot of prospective trials to see if this is actually a real or confounding effect, but it's spawned quite a lot of research. So one of the interesting pieces of research that we were involved with was a prospective trial randomising air compared to oxygen, people coming into a hospital with heart attacks. So if you call up the ambulance with your chest pain and you're having a STEMI, you got randomised to oxygen or air in that study, and it didn't turn out to be benign. The really interesting thing was that if you look at the bottom samples where the p-value becomes significant, the things that became significant were the size of your heart attack on MRI tended to be higher if you were given oxygen rather than air, and CK rises and amount of area under the CK curve was all higher if you got oxygen as opposed to air. This was a study designed to look at these sort of biomarkers. It wasn't large enough to look at patient outcomes, but in actual fact, patient outcomes turned out to be a little different in some categories, and the main one was that the people with air had less recurrent myocardial infarction than people who had oxygen. But oppositely, there was a trend to higher mortality in the no oxygen arm. So it'll lead on to bigger studies. So in general, we don't try and aim for normal oxygen levels in VA ECMO because it requires really careful titration of the blended oxygen to the gas flow meter, and so we pretty much still run hyperoxia for our patients at the moment. People who work here as senior registrars do quite a lot of ECPR simulation training that Chris and others run, and this was in the development phase where we were working out our protocols and our systems and our training steps, so they're all listed there. And the success of the program is having people who know what they're doing, equipment to do it, and a way to have it all set up before the patient arrives so you can crack straight on. To that end, we have quite a lot of point-of-care resources, which are very important for ECMO because it's often something you're not doing every day or every week. So these are cards we give out to all the team members during the cardiac arrest, and you can see from that team leader card, it shows what your role is, what steps you have to take, and how to arrange people. So there's airway people at the head of the bed, there's the ECMO trolley at the foot of the bed, the team leader stands at the bottom left of the patient. The ultrasound device sits on the right so the cannulating one can see it, and you can see where everyone's positions are laid out on the card. One of the areas that interests me a lot is the paradigm of early reperfusion for cardiac arrest. So everyone knows that if you've had an AMI, you want to get to cath lab and have the vessel opened as soon as possible. So minimising the time between pain and reperfusion is important. If you have a cardiac arrest, you can't do the cath lab during cardiac arrest. You can sometimes leave on a Lucas 2 device and try it, but it doesn't usually go very well at all. So there's a necessary step in there for ECPR. And in reality, out of hours, the ECPR doesn't add any time to the cardiac arrest because it takes longer for the cardiologist to come in than for us to commence the ECMO. So that one's easy. The problem is in hours, when they're ready to go, you do add time to reperfusion by doing the ECMO. I'd say for a cardiac arrest, that's a fair trade-off, that you would definitely want your organs supported, and using 15 minutes to prevent brain, liver and kidney injury is probably worth 15 minutes of reperfusion time. Where it gets tricky is the borderline patients. So you've got your STEMI, you may perhaps had a cardiac arrest with ROSC, or you just have very severe shock state and you're at risk of another cardiac arrest. The cath lab will be screaming for those patients, let me open the vessel and it will all get better. And they're right some of the time. The problem is they're wrong some of the time. Some of the time they don't get to open the vessel before the cardiac arrest becomes refractory, or the shock brings down all the other organs, which will ultimately determine the outcome of the patients while they're trying to do it. So we're trying to work out exactly in this algorithm where ECPR and other resus fit in, because at some point they're going to have benefit to the patient inserting them before going to cath lab, but it's really tricky. We'll just talk about what you can expect from outcomes from ECPR around the world. I think that the best evidence we have to the effectiveness of this intervention comes from the Japanese study, the SAVE-J prospective cohort study. So you were allocated by whichever region you had your heart attack in. If you were in a region that didn't provide it, you got managed conventionally and analysed conventionally. If you had your AMI in a region that provided it, you got entered into the ECMO arm of the trial, and then they compared how they did, and it's a large trial. It was designed to have quite clean data of witnessed VF refractory arrests. So that makes it unusual for a start to have a clean population in. The groups were fairly similarly matched, even though they weren't randomised. The groups were matched quite well before they went in. If you look at the time from the emergency call to arrival in hospital, they're both around the 30 minutes, which is a bit quicker than we'd get here, but that's critical to your outcome. What you want to look at here is the bottom lot of CPC numbers. So that's cerebral performance category status, and 1s are good and 2 are just acceptable, and anything below is terrible, you wouldn't really want. And so this is the ECPR group versus the non-ECPR group. And if you allow the dust to settle and you come back and look at them at 6 months, fairly complete follow-up, what you find is 2.6% of people survive. So it's not terminal. If you scoop and run, bring to hospital and have no ROSC by the time you get to hospital, you still have 2.6% of people with a reasonable cerebral performance score. But in comparison, in the ECPR group, it was 11.2, which isn't very good, is it? Like 11.2 for an intervention. But it's a treatment effect of, 5 times treatment, and you wouldn't need a very big number to treat to get that sort of treatment effect. So the question is this a worthwhile thing to do? But I think that's the cleanest evidence we have of the effectiveness of it. There are ethical problems with randomising people in this. So randomly allocating people to no ECPR, if you can provide it, is a bit tricky. It's the strongest evidence, but most people haven't gone down that route. So propensity match study. So this was again that large Korean one with a lot of with a fantastically maintained database, and they were able to very effectively match for age, length of time, cause, all the important outcome determinants. What they found was for matched ECPR versus conventional CPR for all the major outcomes. So in this group here, so that's survival at 24 hours, so you were much more likely to survive with ECPR. Interestingly, to leave hospital, there was no survival advantage. Survival at 3 months, there was no significant difference between the group. There was about 52 people in each arm for this study to get an estimate of its ability to detect a difference. But to have a good cerebral performance score at 3 months, there was a significant benefit for ECMO in that. And again, you get similar numbers of about 15% versus 2% in that group. For in-hospital cardiac arrest, so these are the original Taiwanese group that have published lots of reports on their in-hospital group. You can see here they've also done propensity analysis based on characteristics and endpoints, and found that a good cerebral performance status, say at 1 year, so if you have an in-hospital cardiac arrest and you get ECMO, 20% were alive and functioning at 1 year versus 10%. And wasn't significantly different in that size of cohort. So treatment effect wasn't as good. We published a series here. We had a mixed population of in-hospital, out-of-hospital, and a number of our survivors, almost the majority of our survivors in the ECMO side for out-of-hospital cardiac arrest, never got ECMO. Got ROSC before we had the ECMO and went on to be our survivors. And this is our first 62 patients. So in the in-hospital cardiac arrest, we've had 12 survivors from 32. So, close to a 4 in 10 survival rate to going home. And in the out-of-hospital cardiac arrest rate, we've got about a 16% survival over 30 patients. I think we've got another 10 more in the series that I haven't added to it yet these days. But I think they're pretty good. Two of the big developments we've had in ECMO are development of severity scores, just like Paul presented for the in-hospital cardiac arrest. These are very helpful scores in predicting outcome. We tried to do exactly the same thing based on the largest databases of ECMO patients in the world, and we tried to do the same thing. So the top one was for VA ECMO, and the bottom one was for respiratory ECMO. We tried to do the same for ECPR, and we found that of the data collected, none of it predicted your survival whatsoever significantly, which was kind of interesting. I think it says to the quality of the data that's collected and the heterogeneity of the population and the conditions for which it was given. But more interestingly, we looked at whether survival rates have changed over years since 2003 to 2004, and the finding, even when we adjusted, was no change in outcome over the last 11 years, I think it is there. So I think the next things that we're very interested in doing is getting prospective data sets going forward. And I think what we want is good data, good prospective data collection, but it has to be a little parsimonious. You can't just collect every bit of data you'd like to have, or no one will collect it, or it becomes too expensive to collect. And I think looking at the VA and VV ECMO, it's not that hard to do, and we're hoping to get that done. This is an example of a risk prediction model from a case series from Korea using the following variables: age, presence of diabetes, first monitored arrest rhythm, whether it was asystole or PEA or VFET, whether there was an underlying ischemic cardiomyopathy, whether your CPR to ECMO time was less than 38, your initial pulse pressure was greater than 24 during compressions, or after ECMO, whether your MAP was 57 unsupported, or you had physiological scores of less than 14, created a score, and with that score you were able to create a predictive algorithm that worked quite well. And I think you could probably trim a few of those off and get most of the same answer for prediction. And that's very important because that allows you to compare between different series and see if you're getting better over time. You can't really do it without these scores. They're probably all we need to score going forward. And so the second last thing I'll say is that ECPR has very strong physiological and evidence base to support its use, particularly for out-of-hospital cardiac arrest, I would argue. The large database with accurate data to build risk prediction models are essential now because the practice is getting more and more common around the world. When I spoke about this in Korea, we'd done about 70 of these cases, and in one centre had done 1,000 that year. So just goes to show, yeah, that's it. And so I was forced, once I had that information, to add one more slide at the end, which is the only thing better than successfully treating a cardiac arrest case with ECMO is preventing it. If you look at our rates of MET calls over the years at the Alfred, so that last year is, sorry, the last number's not come out, is 2015, and you go back to about 2000, I think it is there. You can see that we had a sharp, when mandatory MET call criteria came in, we've had I don't need to tell you how many MET calls we get called to and how often, but that's been associated with a falling rate of cardiac arrests, actually. And if you count the cardiac arrests at the Alfred, in 2015 there was only 50. There aren't that many to do. A lot of those obviously aren't suitable for ECPR, would have an exclusion criteria, but there's not much, and preventing them is by far the best thing to do for it. But if you need it, it's a very powerful therapy. So I think we'll stop there.